So I'll start again. So I'd like to thank you all for joining us here this morning for the beginning of this important discussion. And I hope you'll get some interesting insights from the report. The report intends to drive an important conversation about the experiences of cancer patients beyond just their immediate treatment, and the unseen barriers facing them, and how social inequality is impacting Irish cancer patients. The report comes at an important time for our healthcare system in Ireland. As we enter winter, it is expected that our healthcare system will continue to be under pressure, with attendance at emergency departments already 5% up on the same period in 2019. On Taoiseach Micheál Martin earlier this month warned of a frightening wave of delayed cancer diagnoses impacting the Irish healthcare system. Irish cancer patients cannot afford to have further barriers placed in front of them when it comes to the timeliness needed to diagnose and to treat cancer. The launch of this report aims to better understand and call for improved supports for vulnerable patients during all stages of their cancer journey. November is Lung Cancer Awareness Month. Lung cancer is just one example where incidence is higher among people from lower socioeconomic status, illustrating the significant impact that a socioeconomic background can have on a person's health. With improved health supports, patient outcomes will improve, and more people will survive a cancer diagnosis, and more people will live for longer. At MSD Ireland, the patient is very much at the heart of everything we do, and we understand and recognise much more can be done to help improve the experiences of Irish cancer patients and to reduce socioeconomic barriers impacting their treatment and care. On behalf of MSD Ireland, I would like to say a very special thank you to TASC for their work in completing this report and all who participated in the research. I hope that you find today's session informative and useful, and that we can all see some meaningful outputs from this report. Thank you, and I'd like to hand over to Shanna.
I'll be very brief. Thank you very much for coming today. I'm Shana, I'm the Director of TASC. I just want to introduce two people. The first is Jerry, Dr. Jerry Mitchell, who is actually in the UK, and she edited the report. The author is Dr. Emily Murphy, who was an employee of TASC. She was our health researcher, and she's now in the Department of Sociology at the University of Limerick. She's actually due soon, so she's on bed rest. So she couldn't make it today, I want to thank her for her, hopefully she's listening on live stream, but I want to thank her for her extraordinary effort in getting this report done, considering the challenges she faced. And Jerry is going to present the findings. Jerry has edited a number of our reports at TASC. She's very familiar with our work. I also want to introduce the person who's chairing our panel today, who will come up after Jerry presents the findings. Priscilla Lynch, who is the clinical editor of the Medical Independent and a health journalist. So thank you, Priscilla. I will first turn it over, though, to Jerry, who will come on stream in just a second.
Hello.
Just go ahead, Jerry. Just go ahead, Jerry.
Oh, hi. Hi, nice to be with you virtually. And apologies, I was the one that caused that reverb because I've got you on YouTube on my laptop and then I've got the presentation on my computer, so sorry about that. So I'm going to turn my video off now and present just for about, hopefully, between 10 and 15 minutes. Oh, and we'll need to go. Hello?
Just go ahead, Jerry.
Hi. So, yeah, okay, so this presentation is going to take about 10 to 15 minutes, hopefully, but Sheila, please stop me if I overrun. So I'm just going to stop my video. So, MSD Ireland Commission task.
Jerry, your slides aren't up.
Oh, okay. Oh, there you go. Are we open? Can you see them now?
Yep.
Brilliant. So MSD Ireland Commission task to examine how socio-economic inequalities influence access to and delivery of cancer services among disadvantaged and marginalised population groups in Ireland. As we all know, there is no universal access to free primary healthcare in Ireland, and this is especially concerning given the rise in income and wealth inequalities across Europe, and given that, as demonstrated by TASK 2019 research, health inequalities are rooted in socio-economic factors. The following slides outline the study's context, objectives, design framework, key findings, conclusion, and key recommendations. I've just moved it. Yeah, great. It's a bit of a time lag, just to warn you. The research objectives were as follows: to better understand how socio-economic inequalities influence the experience of cancer services and the barriers faced by vulnerable patients, to evaluate how cancer inequalities are monitored and tracked, and how effective healthcare services are at reducing those inequalities, and also to provide some input for the National Cancer Strategy rollout in 2023. I'm just waiting for the slide to catch up. Yeah. The National Cancer Strategy 2017-2026 has underlined the critical role of socio-economic status on cancer mortality rates across Ireland. Certain cancers disproportionately affect lower socio-economic status population groups in terms of high incidence, lower survival rates, lower proportions of early stage or higher proportions of later stage cancers, and lower proportions of patients surgically treated in more deprived populations. This research was framed by a social determinants approach, which is namely the ongoing proven association between socioeconomic and health status. Socioeconomic status includes resources such as money, knowledge, prestige or status, power, and beneficial social connections, all of which protect and improve health. So taking this as our framework or assumption, the research argues that outcomes are not going to significantly improve because those from lower socioeconomic status communities lack those socioeconomic resources and that status. So the report is based on qualitative data conducted between March and June 2022. 20 semi-structured interviews with healthcare professionals, community health workers, oncology experts, representatives of relevant charities who work directly with cancer patients, and including some who work with cancer patients who are in low-income and marginalised groups, and a closed roundtable engaging experts and civil society organisations. It also includes secondary analysis, such as looking at the link between cancer and socio-economic deprivation and the effectiveness of policy measures to date. So the next few slides are looking at the study's findings on two of the most unequal stages of the cancer journey, namely pre-diagnosis and survivorship. A major barrier to adequate cancer care in the Irish context begins at the first entry point into the healthcare system or at the level of primary service access. The barriers to access include first that more deprived areas and communities have much less readily available access to local general practice service than others. And second, that marginalised communities face barriers to being referred by a GP for an appointment with specialised hospital cancer services. So the other barriers listed on this slide may affect screening uptake, decision making, risk perception, including the fear of the cancer progressing, medication adherence and follow-up compliance. And this is a quote from a hospital consultant interviewed about the initial barriers of access. Access to care remains a problem. Once you get in the system, you're fine, but getting into the system is the problem. The major barrier would be the beginning. A major barrier is general practice, and then for general practice, the barrier then will be, with 800,000 people on a hospital waiting list. Just waiting again. Patients will frequently be reticent to come forward for testing, even at the stage of experiencing symptoms, and these are often ignored up until the point of emergency admittance to hospital. For example, with lung cancer, there's blood in the lungs and they go straight to A&E. An additional barrier to diagnosing lung cancer in particular is that, as we know, there's no screening currently in place. Instead, doctors must wait for patients to exhibit and then report symptoms to their GP or healthcare professional if they have one. Yet one problem with this strategy of waiting is that, as one policy officer put it, lung cancer is people feeling partly to blame for their own diagnosis. So psychological responses to cancer, such as fear, shame and fatalism, lead to avoidance behaviours when it comes to ignoring or checking disease symptoms. There are a number of points in the Irish healthcare system at which socio-economic inequalities enter and impact on people's cancer incidence and outcomes. However, the interviews and the roundtable underscored the need to know more about socio-economic inequalities in the survivorship phase of the cancer pathway. This seems the most unequal in terms of who is benefiting from the greater coordination and advances in post-treatment innovations and community supports. A need was identified to support vulnerable populations in searching out and attending a variety of rehab courses or therapy courses, associated group courses, and also for peer modelling and visible roles in the community that advocate a survivorship phase, one that re-establishes and rebuilds a person's healthy identity. As psycho-oncology is such a focus currently in Irish cancer policy strategy, a spotlight must be put on acknowledging socioeconomic status as a huge marker of disadvantaged access. And this is a quote from a chief executive officer of a cancer support centre, describing how current policy isn't helping disadvantaged people in the survivorship phase. The massive and significant infrastructure issues which are existing around not just cancer, but a whole slew of health issues exist, right? So no matter how many people you get out for a walking booth, if you don't have access to that service, or once you get into that service, your experience is dreadful, then, and where you can't navigate that service because you don't have literacy, these issues will continue to exist, and people in effect are set up for failure. The next few slides focus on our findings on the financial costs of cancer. The costs associated with cancer treatment and recovery tend to multiply over a person's cancer journey, but as one respondent noted, a monetary crisis begins at diagnosis. Costs associated with cancer treatment and recovery multiply over a person's cancer journey. They face financial debt and health crisis simultaneously. Costs interrupt their continuity of treatment. There are unforeseen costs such as energy and food. So there's a lack of recognition of a patient's indirect and direct financial costs associated with the diagnosis. There are also many patients who comprise a third tier, which is a group of people who cannot afford private health insurance but find themselves in a financial crisis. So prior to diagnosis, they couldn't meet the national criteria for receiving medical card coverage, but they can't pay for a series of spiralling costs as their cancer treatment progresses. So some of the direct costs of being a cancer patient include accommodation, transport, parking, ambulance fees and A&E fees. And this is a quote from an oncology nurse. Somebody with a cancer diagnosis may feel the cold more and may need the heat on more. We all know right now where we are with the cost of heat and the cost of oil and gas, and tie that in with somebody who now may be out of work. So direct and indirect costs have the potential to set in motion a financial crisis that is extremely difficult for patients and their families trying to cope with the news of a cancer diagnosis. Low economic status increases the risk of falling into debt, whether at diagnosis or through to post-treatment and recovery stages. There needs to be greater awareness of how best cancer patients can be helped to cover these costs, or at a minimum, how they might plan to minimise them once they have a diagnosis. And this is a policy officer. It's very traumatic for people who the first time they shared that they had cancer was with a debt collector, because they were so taken aback by the fact that they were being pursued for these charges. And I'm sure everyone in the room would agree that no person's cancer journey should begin with a personal debt crisis. Across our interviews, there was an awareness among respondents of how reliable and detailed data on inequality in cancer, if collected, would help to identify efficient investment avenues and policies that would be most effective in an Irish setting. Yet the data acquired is still not being captured adequately. There's lack of socioeconomic status estimates available across all populations in Ireland. There's lack of systematic collection of any type of real-time socioeconomic markers of inequality in cancer data. There's lack of prospective and longitudinal data, whether individual or hospital-based, breaking down by socioeconomic inequality, data in relation to cancer trials, cancer chemotherapy uptakes, other treatments or also data on waiting lists. The collection and management of data needs to be improved in order to see systematic improvement in monitoring inequality. Just waiting for the slide to catch up. And this is a quote from a policy officer in a charity. How can you, I suppose, identify where the gaps are and remedy that? And I think for us that means focusing on population-based health, right? But how can you plan for a population if you don't know the needs and you don't have the data? So to sum up on the barriers, these are the key barriers that research has identified to addressing socioeconomic inequalities in cancer incidence and outcomes. So underfunding of GPs, inequitable geographical distribution of services, lack of screening for some cancers, lack of structure to the cancer care pathways, lack of financial advice and support from point of diagnosis, lack of access to and financial support with the use of post-recovery amenities in the survivorship phase, lack of data, and lack of integration, this is really important, and standardisation between public, private and voluntary sector providers, and lack of localised services, which many respondents identified as being really key. The research also looked at the models of cancer care and found that, as I said, better coordination is needed between sectors in order to provide that continuous care. A localised model of care, as I said, one offering community-based provision of cancer screening, care and treatments, and this would help reduce inequalities. And a mapping of cancer and associated services to increase knowledge of care countrywide, and particularly in more disadvantaged residential communities. More equitable funding support for health professionals, and also a change in the hosting and funding model for cancer trials. So to conclude, this report has identified some of the financial, psychological, structural and service-created barriers facing cancer patients in Ireland today. It has demonstrated the need to take their experience of these barriers as the fundamental starting point in systematically redesigning the model of cancer care in Ireland for disadvantaged patients. Understanding the impact of those barriers on patients from pre-diagnosis all the way to post-treatment will not only significantly improve the incidence and outcomes of cancer in lower socioeconomic status groups, but will also transform their experience from simply getting through their cancer treatment to experiencing an improved quality of life. And just briefly, is just some of the recommendations. Just wait for it to load. The first is to set up a task force to gain it's kind of evident that we need a deeper understanding of how all these challenges are multifaceted and work in combination, and which continue to result in certain cancers disproportionately affecting low socioeconomic status population groups. To target policies on structural inequalities, the fundamental cause of inequalities in cancer outcomes and incidence, and to develop cancer services that create more structured pathways of cancer care, including from early screening. To better integrate hospital cancer services with primary care and local services, to ensure seamless patient pathways before and during after treatment, after treatment, during and after, sorry. And then some recommendations for the providers. Just wait to come up. Healthcare providers are recommended to explore broader ways of providing screening services, so for example screening outside of healthcare settings and incorporating other healthcare professionals into the screening process, with GP supervision and training, so that they can identify the symptoms. To provide financial support to minimise patients' direct financial costs and improve awareness of and support for indirect financial costs. To work in partnership with community and primary level services, to develop use of data in improving socioeconomic inequalities in cancer care, and to invest in interventions that are localised and community facing, and that seems to be key from the findings. Thank you so much. Just stop there.
Thank you, Jerry, for your overview of this excellent report on how socioeconomic inequalities create barriers for disadvantaged patients across the whole cancer journey, from pre-diagnosis to post-treatment. Come on. This report looks at areas which are not normally reported on in the literature in Ireland, and it addresses a key information deficit, because if we don't know where gaps and barriers are in services, how can we remedy them? It's also a very timely report in light of the current cost of living and energy crisis and the fears of delayed and missed cancer diagnoses due to the COVID-19 pandemic. I personally found the report to be very accessible, insightful and concise in its findings, with practical suggestions and recommendations that I'm excited to tease out further in our panel discussion this morning. So without further ado, I'm going to invite our panel to come and join me, and I'm going to introduce them. So first of all, we have Dr. Frances Drummond, who is a research manager in Breakthrough Cancer Research, where a post she's held since October 2019. She has 17 years of experience in cancer research in the National Cancer Registry of Ireland and University College Cork. She's published more than 50 peer-reviewed papers and reports. Avril Power is the CEO of the Irish Cancer Society, Ireland's largest cancer society charity. And as CEO, Avril has led the development of the Society's new 5-year strategy, launched last year, which sets out an ambitious vision that by 2025, 3 out of 4 Irish cancer patients will survive their diagnosis, and everyone affected by the disease will have access to world-class treatment, care and support. And finally, Deputy Colin Burke, who was elected as a TD for Cork North Central in 2020. He's the Fine Gael spokesperson on health and serves on both the Oireachtas Public Accounts Committee and the Health Committee. He was previously a senator from 2011 to 2020, and he has extensive knowledge of the Irish healthcare system. Jerry will also join us for the discussion, and we will take questions from the audience as well in a while. So first of all, for our panel, I'm going to ask each of you, can you please tell me what was the most striking finding in the report from your perspective?
Thank you very much, Priscilla, and to Task for a really, really brilliant piece of work. I suppose what I took away from it is the lack of progress. This has been an issue since I remember. The cancer burden in the lower socioeconomic group has been an issue since the registry in Ireland has been established. So that's since the mid-1990s, and we've seen it in other countries. But while that is the case, I do know that on local levels, there are really, really good initiatives being created and carried out that are making a difference locally. So be it some hospitals, UL have free parking for radiotherapy patients. This is super. the local cancer charities are bringing patients to hospitals for treatment free of charge. All this is, voluntary organisations raising money and helping to alleviate those. They're feeding people when they come back. They're giving, counselling services. They're giving other lymphatic drainage. Sorry, my fluency is gone. But they're providing lots of supportive interventions that are evidence-based to improve the lifestyle of both and the survival of patients and survivors. So there's really, really good local evidence. We've got the Marie Keating Foundation who are educating the public on prevention and treatment. We've got charities like ourselves, Breakthrough, who fund research, which is feeding the pipeline to clinical trials, also funding clinical trials, funding key posts like chairs in cancer and translational cancer research in the HSE. And the Irish Cancer Society also funding major research and clinical trials. So while unfortunately at a national overall level, and I also want to point out the foundation of the National Cancer Control Programme has been huge since the 2006 policy, National Cancer Policy. They have been working with they've been bringing together all the voices in the country, like under the Irish Cancer Prevention Network, and through those kinds of programs are really they're facilitating this integration of all the different components of the cancer landscape, really. And I would say that the charity sector has grown as a result of these gaps in the national service, really, I suppose. So in a nutshell, that's where I see, it can be quite a disappointing and kind of despairing type of finding. We also have to remember this is during COVID. It was carried out during COVID, which was extraordinarily challenging for our health system, for the cancer services especially, for access, etc. So we also have to acknowledge that. But having said that, one of the papers in here is from my colleague from the National Cancer Registry, 2013, describing the financial difficulties, the out-of-pocket difficulties, and that hasn't changed. In fact, that's gotten worse in the past year. So that wasn't very succinct, but that's some of the points anyway. Thank you.
So there are pockets of good care. A lot of them are being provided by the charity sector stepping in. So what we're really missing is obviously a coordinated national response that's government-led and government-funded. I think is really what's we're seeing. And for you, what is the most striking part of this report?
Well, I think one of the things that you need to have in relation to having a full assessment what you need really to do a full assessment is having proper data, and there is a problem there. So, and I suppose it's one of the things that I've argued over the last 8-10 years about the computerization of our hospital system. We are way behind in relation to computerization. Okay, it appears during COVID we did target. We reached the 2025 target in 2021 because we had to in relation to COVID. But we need to do a huge amount of work in relation to computerization. Therefore, if you have computerization up and running properly, then you can get data far more easily, and you can then see where the glitches in the system are. And there are glitches in the system, but it's not only the point made about the failure of support after someone goes through treatment. I'll give you an example. Last week, I had 2 young people on to me. One is 24. He is, unfortunately, he's not getting any family support. He has both lung cancer and he has stomach cancer, and he's currently in temporary accommodation. And I was met with a senior city council official in Cork on Friday night to see if we could sort out housing for him, because he needs that kind of care. I had a second person into me on Saturday. She's 21. She went to her GP. I think she was coming out in red spots, and GP didn't think there was anything serious. This is 2 years ago. On Christmas Eve, she started coughing up blood and was diagnosed initially with leukemia, then was diagnosed with I mightn't pronounce this right, aplastic anemia, and she had to get a bone marrow transplant. She got bone marrow transplant from her brother was able to assist her, but she is, herself and her mother are now living in rented accommodation. They're looking for local authority housing as well, and there is no connection between the health service and the local authorities. And there are 2 examples just into me in 1 week where the necessary support that those 2 people need isn't there for them, and that's one of the things that we need to make sure that all of the systems click in together, and we need to do a lot more coordination in relation to that area. Just in relation to healthcare overall, there is a big challenge now in relation to healthcare, in that the population of the country has increased by 1.2 million in 20 years. That's 60,000 people per annum. We haven't expanded the healthcare sector in the same manner in order to deal with that increase. And one of the frightening figures that's just out in the last week is this year, I think the population will increase by a lot more than 60,000. For instance, in the first 9 months, there were 232,000 new PPS numbers issued. There was 55,000 for Ukrainians, 53,000 Irish, 14,000 Brazilians, 14,000 Indians, 14,000 people from India issued with PPS numbers here. So 232,000. So it gives an indication of the growth in population here. The issue about medical services is that it needs to expand in a far faster mechanism, and the decision making about expanding is taking far too long. Even simple things like whether you want to build new facilities, get new equipment, the whole process seems to be taking maybe up to 3 to 4 years for very simple things, like where you have people who are dealing with cancer care, they want new equipment, and they're finding it's taking ages to get a decision made, and I think that process needs to be expedited.
Absolutely, some very good points there. I suppose silos in healthcare, we hear about the community not connecting with the hospital services, connecting with the support services, with the cancer support charities. But then, as you pointed out as well, just across government, across departments, that there is no connection there currently between housing and other supports really for people with cancer who desperately need to have those services in place. So, and then obviously the data as well. I've written a lot about the electronic healthcare records over the years, and it's really disappointing to see that we've had a plan put together, it was costed, and the government just bought at it and just said no, that's too much. Yet here we are some years later, and there's a huge lack of data and interconnectivity, and people fall between the cracks, as you pointed out there. And also the population increase. I think a very good point there, Colin. The HSE for the last number of years, after regular briefings, have been telling us about the increase in people attending emergency departments, and we've been looking at the reasons why. Quite simply, a big part of that is the population increase. It's not that people are turning up to services because they're not going to the right services. We just have a much bigger population, and we haven't got the healthcare staff or the bed numbers really to accommodate that. Never mind the population we would have had 5 years ago. So Avril, I suppose, what are your kind of key takeaway messages from this report today?
I think the key one for me is that it's sad to see that the benefits and the progress that we've made in cancer services over recent decades isn't being shared equally. And as Francis said, it's not new, but it's stark. It's just horrifying that you're much more likely both to get and to die from cancer if you live in certain areas. There's been research done before showing that rate of cancer deaths is 3 times higher in Mulhuddard than in Castleknock. You know, 2 areas that are side by side, and you mentioned earlier the postcode lottery. And that research is some years out of date, but there's been no follow-up done on that. We don't know what that looks like now, and unfortunately, sadly, we don't have reason to believe that it's any different. And particularly with the impact of COVID, we know that the problems, you know, these are not new problems, they weren't created by COVID. We're heading into another winter, we're talking about the winter surge, and you know, people are being advised not to go to EDs, but then we see that for great many people in our community, they've nowhere else to go. They can't get into GP services. If, you know, cost is an issue, but even for those who have medical cards, the services are oversubscribed. It's very, very difficult to get an appointment. Big pressures on urgent care and other services. So, you know, for many people, these problems aren't new, but they're more acute. And I think the other big challenge in cancer services at the minute is the delayed diagnosis caused by COVID and the backlog that's there. And with cancer, as all of you know, with cancer, time is everything. It's the difference between life and death. And as we saw from this report, that's one of the key. There are many reasons, and they're not simple. But one of the key reasons why you're more likely to die from cancer if you're from a disadvantaged area is simply that it's more likely to be caught later. And we've funded research and published research in the past on ED diagnoses. And that if you're from lower income groups, you're more likely to be diagnosed in an emergency department with an advanced cancer that's extremely difficult to treat. And if it can be treated and you do survive, the impact on your quality of life of harsher late stage treatment is so much more. So, I mean, from our point of view, is that look, this research isn't new, but I do think it's horrifying. We should never be immune to it, and I think it really needs to serve as a wake-up call to put the services in place, and also to make sure that those are targeted services, because it's, again, you know, it's sad to see that we have a cervical check program, but uptake is not even, you know, and then among disadvantaged groups, that the report specifically calls out lung cancer, stomach cancer, head and neck, and cervical cancer as the cancers that people from disadvantaged groups are more likely to, where the biggest survival gap is vis-a-vis those who are most advantaged. And that cervical cancer is one of those, I think, is a wake-up call to all of us to see why are people from those communities not accessing screening services, and how do we design services to make sure that they're genuinely accessible to everybody rather than just providing one size fits all that doesn't work.
And that is a key issue, isn't it, that we know where some of these problems are, but we don't act on trying to resolve the issues at hand. And I suppose, being a healthcare journalist for nearly 20 years, I do know doctors who have spoken out on behalf of their patients, particularly in lower socioeconomic areas, saying there's a higher incidence of lung cancer. But what has happened 20 years later, really, those gaps are still there, and they need to be acted on. So Jerry, I'm going to come back to you, because you gave the overview of the report there, and there were some stark findings. But I suppose, from your point of view, was there anything in particular that you want to emphasise or that struck you from your work on the report?
Hi, can you hear me?
Yes, we can, thank you.
Hello?
Yeah, we can hear you, Jerry. Go ahead.
Hi.
You can pop your camera on as well if you like.
Oh, okay. Yeah, I suppose, and I've got a good friend who's just had their first breast cancer operation. I think I was thinking about this anecdotally in terms of my own experience as well. I think the main thing is that life doesn't stop for cancer. And my friend, for example, she still has to make I took round a macaroni cheese the other day, she still has to make the meals, she still has to look after her children, she still has to face going back to work soon. So cancer is increasingly part of life, I think, is the main thing that struck me. And I was just looking at the executive summary of the current cancer strategy. And it just says, there are over 150,000 cancer survivors in Ireland now, and a greater focus on the increasing numbers living with and beyond cancer is required. So I think basically just to take the report and think about, what are those other parts of life that need to keep on going, and how can we really support, because those may be the things that are actually very, very stressful. So, right until the point my friend was going to an operation last week, she was thinking about her children. It was actually one of her daughter's birthday the next day. She was like, have I got the balloons ready? That's literally the last thing she's thinking of, as most of us who are mums would understand. So it's really trying to support people with all those indirect financial, indirect direct costs, and give psychological support. But just briefly, there's sort of two areas. There's a lack of awareness of what is out there, but I'm also very interested in how we make spaces welcoming, how to access. There's so many different dimensions to access. And I think one thing that struck me was that higher socio-economic status groups tend to use voluntary sector support centres, for example, because they've been set up by certain groups of population, say more middle class, and they feel, and this is direct quotes from interviews, people don't feel comfortable coming into these spaces. They're just culturally not right. So how to create spaces that don't feel discriminatory, that feel welcoming, that can support disadvantaged patients is just a couple of things that I was particularly interested in.
Thanks, Jerry. Yeah, that was a very interesting finding in the report, that there were some amazing support services out there for cancer patients, particularly in the survivorship phase, but a lot of them are in the leafy suburbs, and they can be intimidating to many groups to access these, and I suppose just to feel comfortable going in there. So that definitely is food for thought about the design of services, and also the geographical inequality in those support services and having to travel to get them. And also, even in the area where I live, there is actually a charity that provides cleaning and childcare services for families impacted by cancer, and that was a very practical thing. But again, that's just in a particular area where I live. That would be a very useful type of service to have, nationally. So I suppose it's really finding where those gaps are and trying to bring in more national services. And Avril, I suppose, from the Irish Cancer Society point of view, you plug a lot of those particular gaps for patients, don't you? Particularly at this time, cancer is a very expensive thing. You provide various services that help people practically, and you have a fund as well that I'm sure you will get a lot more demand for in the coming months.
Yeah, I think as Jerry said, life doesn't stop for cancer, and then I think also cancer sadly doesn't stop when your treatment stops. It has an impact on people's lives for many years after that. Obviously it varies from person to person, but some people will experience fatigue for years afterwards. The emotional impact of cancer, depression, infertility, even for women and men who go through treatment at a young age, and that even in childhood, them not being able to have their own kids as a result. And that's something that we've just started funding a service on 2 years ago, fertility preservation. So there's so many different aspects to it, and I think in the past the focus was, and rightly so, on making sure that more people survived the disease, because when we only had 30 years ago, only 3 out of 10 people survived. So the focus for government and for charities like ourselves was, how do we get those numbers up? How do we make more survivors? But I think now the challenge is both to keep that progress going, and we won't settle until everybody survives cancer, but also to make sure survivorship means something, and that people have a decent quality of life. So we provide services like counselling. You mentioned the volunteer driver service, bringing people to and from their appointments. We fund counselling, we fund play therapy, peer support, fertility preservation, and we're starting new services. At the minute, I'm on giving people access to dietitians because they can't get them through the public service, exercise supports. So there's a whole range of holistic supports that are needed, and they're not yet consistently available through the public service. It can depend a lot on, like, if some hospitals you go through, you will automatically get access to a dietitian, another you won't, and it can have a huge impact on people's treatment outcomes, and also on their quality of life. So we're trying to plug those, and we're fortunate that we get the funding from the public to be able to do that, but there are huge gaps, and it shouldn't just fall to charities to do that. And the other one is, like you mentioned, say the financial side. There's a huge financial cost of cancer, and people are out of work as a result of getting a diagnosis, but then being hit with extra costs for everything from transport to get to the hospital, parking, accommodation if you stay overnight, for example, with a sick child and you have to stay up in Dublin where they're going to treatment in Crumlin. There's so many financial costs that you don't think about until it hits your door, and that put people under enormous pressure, both during that treatment and then for years afterwards, trying to recover. So there's so many different aspects to this, and they're, for anybody going through cancer, they're tough. But for people going through cancer who have other disadvantages, who are coping with other things in their lives, who have lower incomes, they're just not in a position to cope with that. And I think that's just really cruel, and I think you need to look at yourselves as a society when you have cancer patients that can't afford to heat their homes in the winter or can't afford to get to their treatment. We have doctors that tell us, we've an oncologist on our board, and she tells us that people miss their appointments because they couldn't, just physically couldn't get there, so couldn't get someone else to mind the kids for them. And I really just think that's, in 2022, that's not acceptable, and that's why reports like this have to be a wake-up call to all of us to do better.
Absolutely, because as a healthcare journalist, I report about new treatments and how important it is for patients to be able to access them. Some of them are very expensive, I mean, tens of thousands, hundreds of thousands. But if a patient can't afford to come to hospital in the first place, or have someone mind their children, or heat their home so that they can be well after receiving such an expensive treatment, which can impact how it works, I mean, really, you know, there's a huge gap there, and that is something that really hasn't been put in place. And we talk about cancer centres of excellence. Excellence in what areas? You know, there's huge gaps. Dietetics is a massive gap across the healthcare system, and as you've shown there, that cancer societies are plugging that gap. The Irish Cancer Society, the Marie Keating Foundation, but for people with good literacy, that's okay. They can reach out, they can get there. But for people who don't, how do they even find that? And something as well that I've seen is, we're very generous in Ireland. People set up GoFundMes to access healthcare, but I've seen a lot of GoFundMes recently for cancer patients simply to travel to Dublin from, say, Cork, from Kerry, to have those accommodation costs covered, and people are chipping in there, and you know, that is something, again, as you said, because otherwise people would miss appointments. During COVID-19 though, one thing that actually came out that was something that doesn't cost anything was actually that, not for actual treatments itself, but for follow-up appointments. There's a lot of follow-up appointments for cancer patients, and that they were able to access them online and not have the cost of having to travel, particularly the cancer centres for patients in Donegal, having to travel long distances for a 10 or 15 minute appointment. That it was much more convenient and cost effective and comfortable for the patients to be able to get that at home. And there was a reluctance by some in the healthcare system for that. They just weren't used to working like this, but it has to be more patient centric to reach out to those patients. Colin, one thing that was, I suppose, really a big point in the report was the lack of access to GPs. We know already that currently the majority of GPs just can't take on new patients. I think with COVID as well, people are more reluctant to go in to bother their GP face to face, but a lot of cancer is picked up opportunistically when people can access their GP. But in Ireland, we've been wringing our hands, and you know, it's very slow, as you pointed out there, the solutions to increasing the manpower. We know there's a global manpower crisis, but if you look around Dublin City currently, there's advertisements for doctors to go to Australia and New Zealand. They simply, in areas of Australia where they, you know, it's very rural, they literally offer a lot of money for GP. That's how they vote it in. Yet we don't seem to be able to think, right, we'll give a decent extra portion of income for doctors to work in disadvantaged areas. Why can't we do something like that?
Yeah, well, we have a big problem now in relation to, it's not just in relation to GPs, it's also in relation to doctors working in hospitals in Dublin. The cost of accommodation, for instance, if you go to the UK, in a lot of hospitals you have accommodation on the hospital grounds for nursing staff and for junior doctors. We've built the hospitals, but we have never actually built the support services that we require for the staff. And for instance, you take the new children's hospital, when it's finished, what kind of staff numbers are we talking about? Where are they all going to live? You know, they will find it difficult to get reasonable accommodation close to that hospital. And we have not built any accommodation for them. And I think it's one of the things that we need to start looking at. You know, you go to universities, we allowed the universities to expand at a phenomenal rate going back 25, 30 years ago, but we at the same time didn't build student accommodation. Now we're trying to catch up. And maybe it's time now to look at this whole issue in relation to accommodation. In relation to GPs, it is going to be a challenge trying to keep them here because, you know, you're competing now on the world market. You can go to Canada, to the States, to Australia, New Zealand, and for instance in the UK, I was over in the UK 3 or 4 years ago, and we were down in Plymouth, and you know, they were telling us about how they had now achieved the waiting time, the particular GP practice we were in, from waiting time to see a patient from 14 days down to 8 days. But while we were over there, we found that there was one GP practice which had 20,000 patients, and all the GPs resigned in one day, just walked out the door. And none of the other practices were prepared to take the patients. The local hospital ended up having to hire doctors to make sure that the hospital didn't gets snowed under. But it's a huge challenge in the UK. For instance, there's a shortage of about 5,000 GPs in the UK. So the problem that we have here is how do we make it attractive to keep the GPs here? We need, in particular, we need to give more support in relation to staffing. For instance, the monies they get for employing nurses, that needs to be increased. The money for employing care assistants needs to be increased, because there's a lot of procedures that nurses can do. They're very well qualified, they can do, that GPs are doing at home. Therefore, you can actually get better value out of your GP practice if you give the funding to allow them to employ additional staff. And that's one of the things that we should start doing, and we should start doing that now. As I referred to earlier, the increase in population, therefore the increase in the GP practice I'm in, for instance, there were 2 doctors in it. They've taken on an extra 3 GPs, but this is down in Cork. But they have people coming from as far away as Tipperary down to them, because the people in Tipperary can't get access to GP up there. But the reason they're able to take them on is because they've taken on 3 extra GPs.
That's a very good point. I mean, there's a huge delay when you're looking at medical contracts and national agreements. But if you look at general practice nurses, I mean, they're a phenomenal resource in general practice. They're underappreciated. They don't have a particular contract for themselves. But that's something that could be done very quickly to increase that funding, to fund general practice nurses, to be there more as a triage service as well. They obviously they are the chief, I suppose, cervical check smear takers in Ireland. But they also have great knowledge when it comes to maybe looking at patients and just talking to them, seeing if there are any particular risks for cancer. So that is perhaps a suggestion that would help some of the points that were highlighted in the report today. Also as well, I suppose, as we said, the joined up services, not having access to each other, working in isolation and in silos. And I suppose, Dr. Drummond, I suppose from your research, we heard a lot today about the lack of data, but cancer societies fund a lot of research as well as patient services. And from your perspective, you've worked in it for a very long area, I suppose really what has come from that, or what needs to come from that to change?
Okay, there's a few things. Research is essential for improved outcomes. And we're talking about lung cancer, ovarian cancer, some of these poor prognosis cancers. There's not enough research being committed nationally and internationally in these cancers in order to improve knowledge, so that we can then improve diagnosis, improve treatments, have more treatments available. We know that people treated in university hospitals, which are linked to universities that have research in them, they do better. But still only 2% of our population in Ireland have access to clinical trials and these newest treatments. There was a new study recently which showed that Ireland per capita has the worst survival compared to the financial input into the health system. That our Irish patients don't have access to the newest treatments. So that's inequality. We know that for lung cancer there is a screening available, but that's only available privately in Ireland. So for those high-risk lung cancer patients, that's not available for the lower socioeconomic groups. Research, so some of the cancers we're talking about, so lung, like I said, it's the biggest killer in Ireland. We need to start the conversation to stop the shaming and start the conversation about lung cancer. I was speaking to a group of researchers recently, and they said the biggest risk factor for lung cancer is having lungs. Because there's been a big study recently that shows that the pollution in the air has a huge impact on lung cancer etiology and starting. So we need to stop the shaming, and we need to get improved, and this is where charities like Breakthrough Cancer Research, we're funding the poorest prognosis cancer research, because cancers like pancreatic cancer, it's 10% survival at 5 years. They increase, or they survival in breast cancer and prostate cancer are 80 and 90%. Now testicular cancer 99% because of the investment in research, which has led to improved diagnosis, improved awareness, improved education of the public, and improved treatment, and improved survival afterwards and interventions afterwards. I did a study a few years ago. The amount of depression, anxiety, distress, fear of recurrence in survivors is huge. 25-30% of survivors have a clinical level of depression, anxiety, distress, fear of recurrence, and these aren't being addressed, and like 8% are on medications, but then they're not being referred for psychotherapy or whatever. Now, one really good intervention that has happened is the increase in psycho-oncology in the last 2 years, and the employment of Helen Greeley to really develop this nationally. So that's really important. And she has started also to standardise the cancer centres so that the interventions they're giving in the psychotherapy area are up to scratch and are helping people. So there is integration that way, and again, that this is coming from the national strategy. So there are incremental improvements. But still, in 2006, psycho-oncology was supposed to be a major, investment for the government. But in 2017, only 1.5 of the cancer centres had a psycho-oncology service. So this again is a great thing. But as you said, the e-health, which was exploded during COVID, has really, the benefits of e-health is gone, and this was another MSD funded study that we did in Cork with UCC and Breakthrough. Huge advantages, as you said. The person in Donegal, the person in Kerry does not have to travel 3 hours to go for their appointments. But also, men, we have to understand, have a higher burden of cancer as well. During COVID, many more men availed of counselling services because it was more accessible to them. And can't throw out all the really good things that we learned worked during COVID, which I think is happening, unfortunately. So we need to just a little bit more joined up thinking,
Those are some very interesting findings, and if that research hadn't been hadn't been carried out, we wouldn't know about it. Yeah. But I cover the UK healthcare service as well, and I'm always amazed at the amount of data they have there. They collect data on so many elements of the healthcare services and delivery of services and outcomes beyond basic survival that we simply don't.
Mm-hmm. That was the other point of the question that you asked. We don't. And again, it's individual studies that are collecting quality of life data, and all these are funded by charities again. So there's no national collection of quality of life data, and our cancer data is years out of date also. So the national cancer. So it's really hard to develop services, population-led services, if our cancer data is 5 years old already by the time we get it. So that there needs to be more investment in that. We are lucky to have a national cancer registry, and many others only have kind of hospital level or whatever. But we're very lucky that way. But it's too out of date when we get it, so we can't. It's not live. So we do need that, and we do need also to look at this third tier people. So those who the middle squeezed, because they're really, really, really kind of left behind it for all interventions. So those who can't afford health insurance, or they have a level of health insurance but it doesn't cover them for everything, they're still paying for their consultant fees, etc., and they don't qualify for a medical card. So those people are in real difficulty and getting worse.
Just to clarify that, I think in fairness, anyone who doesn't have a medical card and they don't have private health insurance are entitled to go into the hospital system under the hospital services card.
Yeah.
So they are entitled to get free care, because I think that's important to emphasise. Okay, they're liable for charges for up to 10 days at €100 per day, to a maximum of 10 days for any 1 year. But all other services are provided without cost. And the other thing in relation to anyone with cancer, okay, sometimes we have to fight with the Department of Health about issuing medical cards, but the vast majority of people that are diagnosed with cancer do get medical cards.
I suppose that, again, there's a lot of inequality there, and for Francis has pointed out, when you do have cancer, and if you don't have a medical card or health insurance, you have to go to the GP more often. There's a lot of support services that medical cards do provide. There was a lot of advocacy work that went into getting easier access to medical cards for patients. But one good thing the government has done very recently, I suppose, we're phasing out inpatient bed charges. They've signed the legislation for that, and they're going to be removed. That was a big cancer burden, as was pointed out in the report. The debt collectors chasing cancer patients is really one of the most awful, I think, healthcare stories that any healthcare journalist writes. It's a disgrace. And even for parking charges, and as you pointed out there, some hospitals don't charge for parking, yet hospitals are so cash strapped that they don't want to stop charging for their car parks. But how do we try and support patients who really just can't afford it? It's very uneven, but as we said, there are things that are coming into place. Going as you've mentioned there about getting rid of the bed charges and other charges. Avril, I think you want to come back in there again as well.
Yeah, and that's what I was going to just say in relation to inpatient charges. Yeah, that's been one of the most positive things. It's something we campaigned on for years, and then particularly the use of debt collectors to then collect those charges. So it is really positive to see that happening, and there have been other positives. We've had funding for the first time in the last 2 years put into the National Cancer Strategy. But I suppose one of the challenges is we don't know the impact of that when we have data that's years out of date. And it's just how can you plan anything, any service, let alone a national health service, when the data that you're using is 3 years out of date, when we're making decisions now based on pre-COVID data, and we actually don't know the real impact that COVID had on cancer services. We extrapolate some of it. We know from, say, for example, we rapid access clinics for the 4 main cancers, so we extrapolate that and say that the diagnosis through those was down 10% in 2020. So if it's the case that was the same in other services, then we underdiagnosed 2,000 cancers that year, but that's a guess. That there are 2,000 people who didn't get their diagnosis, and yet that won't be the case, because those are the ones with a fast pathway. So it's most likely to be much worse for other cancers that don't have rapid access clinics. But not having that data just means you can't plan, you can't monitor progress, even when good things are done, and there have been positive changes made in the last few years. It also meant during COVID, we simply couldn't even identify as a country cancer patients or the immunocompromised. So for example, in the UK, we know that cancer patients, and particularly those with blood cancers and other immunocompromised groups, were more susceptible to cancer, much more likely to have a bad outbreak to COVID, much more likely to end up in hospital if they got it. UK, they identified them from a central list, contacted them, put them through a fast track. If you get COVID, this is how you'll access the system, this is how you'll get the medicine that you need, the targeted care that you need. In Ireland, we still don't know. We still don't have that list. We don't have a central list. And I think it's a huge gap not having that data. The other thing, sorry, I just wanted to say briefly, was on the community piece. Like I said, we have screening, we have other services that aim to reach everybody, but the challenge is bringing those into the community. One of the things, positive initiatives that we started this year was working in the Capuchin Centre and partnering with them and GPs in the deep end and bringing in, we've been a detection service that held a roadshow that's gone into that community to work with them. And it's the same in disadvantaged communities. There are organisations on the ground that are trusted that can break down some of those barriers that unfortunately can be there with doctors, where people feel that they'll be judged, or they feel that their level of education means that they can't question the doctor, or relationship is difficult for them. There are organisations working in disadvantaged communities all over Ireland who have those relationships, that have those connections, and it's how we connect that up so that it's not just about them going to the primary care service, it's about them going through the men's sheds to get access to screening, or go through other trusted groups in the community.
That's a very good point, because even hepatitis C and HIV, there's a number of groups on the ground to reach those marginalised patients, and in recent years they began rolling out community clinics where they can actually have their livers assessed, or that they can try and receive their DAA, direct-acting antiviral treatment in the community, and that seems to work very well. So partnering with those kind of organisations with that existing knowledge of that marginalised patient base is very important. As you said, that there are groups there, so how do we reach out and work with them in cancer as well, because again, it's just not something really that we're used to doing, that we're comfortable doing. And for patients attending emergency departments, I know St James's has some great initiatives with community workers, literally going out into the community to get those patients. And Colin, I think, did you want to come back in?
No, I think one of the biggest challenges I find in dealing with people is someone who has cancer, who has a young family, and they have a mortgage, and the lack of supports then that are there. And that's hugely challenging, especially if they're in a job where the employer, they don't get any sick pay while they're out, and it's a huge difficulty for families trying to keep their head above water. I've seen people, get all they're paying back on their loan is just the interest and not paying back any principal. They get an agreement from the bank, but that's even difficult to get. But it's a hugely challenging time. The other issue that I just want to raise, and that's in relation to genomics, and about how we have that's not really up and running in Ireland at all. For instance, there are more people involved in genomics in Northern Ireland than there are in the South. In relation to the whole healthcare system, we need to be doing a lot more on that. For instance, identifying if a member of a family identifies with a particular cancer, are there other members of that family also likely to get cancer, and should they be screened at that time? We've no system like that. We could be doing a lot more in all of those areas, and I think that's something that we need to start working at.
Absolutely. I mean, that is a key issue. If you come with a particular disease, even liver disease, and if you're at risk of non-alcoholic fatty liver disease, if you have that, and then your children are obviously at risk, nothing will happen until literally they progress to being symptomatic and being diagnosed. There's no preventative strategies. And as we know, as you said, that people in the most marginalised groups who have those hereditary cancer risks, there's no help there to bridge that gap. So Avril, I think you want to come back in again, do you there?
Yeah, just Colin's made a very good point, and it's great that we have the science now to be able to do this, to be able to identify the BRCA gene and Lynch syndrome and other genetically related cancers, or higher risk of getting a genetically related cancer. But I think the problem is often as well that even where people get that news that they can't then take, that's only good information, like that's very distressing information to get if it's not followed up immediately by counselling, by being able to actually talk with somebody about what it means, and then also access to preventative therapy where that's available, preventative surgery or other preventative therapy. So it's actually awful that the science has progressed and that we're able to give people this news, which in some cases means you've up to a 90% chance of getting cancer, and then not actually being able to step in and offer them the supports to help with that.
Speaking of that, I suppose one of the starkest cancer areas identified in the report were the inequality in lung cancer in particular in Ireland. And we know you're obviously more likely to smoke if you live in certain areas, if you're in certain socioeconomic groups, and there's that sense of stigma and fatalism. Now, we only screen for a small number of cancers in Ireland: breast cancer, cervical cancer, bowel cancer, but there is growing support to introduce targeted lung cancer screening. There is the evidence to support that by simple screens. And this would be an ideal opportunity, wouldn't it really, given that the population impacted are among the most marginalised, to reach out in the community. So if we do introduce lung cancer screening, that it's not just in these intimidating buildings and hospitals, isn't it that opportunity you want that to happen?
In 2019, February 2019, we published a lung cancer action plan, and one of the things we called for in that was lung cancer screening in the community based on the model that was put in place in the UK. Our partners Macmillan worked with the NHS in Manchester to develop a community lung cancer screening project. So you're going into communities, and again targeting particular disadvantaged communities because the rates of smoking are higher, and giving people free CT scans to identify if they have symptoms of lung cancer, and then fast track them into getting treatment. Lung cancer is the biggest cancer killer in Ireland. It's the cancer that causes the most deaths, also predominantly found in disadvantaged areas. And I think the only way to tackle that is actually to get into those communities. But I think the other message for me from this report is that you need to do that in a really supportive way and be careful about that, because I thought the messaging was really strong where it said that, you know, people feel that they'll be blamed. So the people who've been smoking, you know, people who've been smoking all their lives, they notice that they've got a cough, or they feel that there's a potential lung cancer symptom there, and they don't seek medical help. So, you know, they don't go to the GP, maybe they won't even go to screening unless we can get the messaging right. And I just think it's awful to think that smokers blame themselves for that or feel that they'd be judged. Like, the only people to blame for smoking related cancer are the tobacco companies that got people hooked when they were kids. And the, you know, predatory tactics that they've used in the past and continue to use and are using now through vaping, getting our you know, teenagers were finding vaping rates are on the way back up, just as we were getting smoking rates on the way down. They're the people to blame, not smokers. And I think you know, there's an impetus on all of us, including those in the charity sector, to look at our messaging and make sure that when we use healthy living messaging, when we talk about the dangers of smoking, that we're not isolating people, that we're not making them feel judged, and that they feel that all services are genuinely available to them and supportive.
And speaking of, I suppose, lung cancer and fatalism, the message is still out there that if you have lung cancer, you're going to die. And the reason for that is the survivor rates are very poor because of late diagnosis. But writing about, I suppose, cancer therapies, there's been a lot of positive news in the last few years about immunotherapies for lung cancer. So I suppose messaging as well, you have to get out there that there is treatment available, it is improving, and the sooner you come forward, the better. I think we're going to move into the audience to take some questions as well. Now, you've been very patient. So this lady here, would you like to tell us who you are and address your question to the panel?
Yeah, hi, I'm Liz Yates. I'm the CEO of the Marie Keating Foundation. And just on your point in relation to lung cancer, obviously it's Ireland's biggest killer. We know most patients are diagnosed at stage 3 and stage 4. And we also know in the last 10 years the amount of advances in the treatments that are now available have been absolutely incredible. And I suppose sinking in with the topic of inequalities of access, the lack of awareness about signs and symptoms, the stigma barrier, which, you know, is a huge cause why patients are presenting at late stage and not being diagnosed early. And it's extremely frustrating to see how much progress has been made by different organisations around the country, but not in a systemic fashion. You know, the information that was revealed today through the research, and congratulations to MSD and TASC for supporting this. It's actually not new, and it's extremely frustrating 10 years on in working in cancer service to see that the survival rate of lung cancer are still only 20%, you know, due to the same factors, due to the inequalities in terms of access, in terms of, you know, access to services all along the pathway. What I would like to see, Avril mentioned that there's been massive investment into the National Cancer Control Programme over the last 20 years. We have not seen that on the ground. So the Marie Keating Foundation, the Irish Cancer Society, Breakthrough Cancer Research, Overcare, all the cancer charities, the local support centres are plugging those gaps in terms of financial support, in terms of psychological, emotional, dietetic, those holistic services, supporting people along the cancer journey. We're not getting, we get zero funding from the National Cancer Control Programme, even though all of our services are in line with the National Cancer Strategy. It's the same with the Irish Cancer Society, same with Breakthrough Cancer Research. A sense of urgency needs to be put on, you know, cancer services. We know we've gone backwards in terms of COVID. The number of diagnoses is going, but we can perhaps see a disimprovement in the survival rates of lung cancer next year, despite the amazing treatments that are now available. And it's just not good enough. You know, so it's immensely frustrating to often hear some of our politicians calling cancer services of the darling of the health services just because we have a strategy, just because we established the NCCP. More progress needs to be made, more urgency needs to be put on the funding. There are fantastic initiatives being created and being run by the different cancer support services. They need to be funded by the NCCP, and then the joined up thinking needs to come to actually meet the recommendations that were put out there today in terms of, you know, that holistic services for access, for working with the community in primary care, and ensuring that those support services are available for patients right through the journey.
Thank you, Liz. Great contribution there. Because as you said, you are plugging gaps in services. I know that you go around into the community, even from an information point of view, and from survivorship as well. You do work with prostate cancer patients. There's a lot of services that even doctors would refer their patients to you, because you do provide those talks, information even on pelvic physio, with issues for men, those follow-up services that, you know, depending on what area you live in, it's very hard to get access to them, yet you aren't funded to provide those services, and often cancer charities are the first to be cut, their funding cut, when there is a crisis in the healthcare service. So it's one thing to fund these expensive treatments for patients, which are great, and access, but there's a whole range of holistic services that need to be funded. And I'm
just to say we're calling this year, this month, as Lung Cancer Awareness Month. We have a petition running online at the moment calling on the government to introduce and look at lung cancer screening. And as Alfred says, it's not the screen, it's the community-based, looking at the high-risk population, those who have smoked in the past, those in the deprived communities, and a simple lung health check will enable them to be tested and get that early access. So just to ask everybody to support the petition for that.
I suppose I'll go straight to another question because we're running out of time. But I think Professor Luke Clancy, is that you? And there's another lady as well after you.
Luke Clancy, Director of the Tobacco Research Institute. I'm not going to talk all the time about lung cancer. I'd like to congratulate TASC on this report. And I think the most important chapter is probably one, direct financial costs of cancer. I mean, as doctors, we're always trying to get more resource for investigation, treatment, all of that. And I don't think during my life I spent hardly any time on this aspect. Here are these people who are being impoverished by their disease, as well as the fact that they're more likely to be poor to start with, and do nothing about it. Now, this data collection comes into this, but there is a lot of data collected and no linkage. These are things that doesn't cost. You know, you brought up the point, we've been talking about this for decades and not doing it, but linkage wouldn't cost. We don't have access. There's a lot of information about people. It's not available to anybody, and it's guarded and it's in their interest. So that's one of the things. But would I say, you said yourself about parking charges, which is a hobby horse of mine. When the diagnosis of cancer is made, why is it that things don't automatically happen? I know the politician told us that the hospital services have now become free, but there are things. We don't need data to know that if you have to park, you're going to have to pay, and sometimes for hours. And then when you get unwell and you have other people bringing you, they have to pay for hours. Why is that not automatic? And also the services that are available, you have to work at them. You go to see the social worker, you go to see the other person and the other, 5 or 6 different people for things you know you need and that I know you need. So why don't things become automatic? Things are very costly, but part of that cost is the bureaucracy around them and making sure that somebody doesn't get them who doesn't deserve them. You know, how much do we want to pay for that? If you carry this diagnosis, why don't you have certain things? And one of them should be free parking. You mentioned the hospitals are under stress, so they have to collect. It's not only that, it starts before that. It's part of the business model. You know, how much are you going to get from parking? How much can you squeeze out of people who can't afford to be there anyway? And that's something that could be done at a stroke. It was wrong. It was not always so. If you're old enough to know that it wasn't always so. Why is it now? We're spending all this money. Cancer is really expensive. And yet the things that make people poor around it, we don't do them. And the other thing, if I have any criticism to report, is that there isn't enough about prevention. there's all this thing about shaming, and I don't want to go there, and I understand it very well. But prevention with regard to lung cancer is about smoking cessation before they get it. There's no shaming in that. Those services are there, but they're not highly paid, and they're not costly. We don't mind treating the lung cancer, but God, treating the smoker for his addiction, that we couldn't afford that. So we've got to get reorientated. I don't like to hear it'll cost too much, and we don't have the information. We don't have the information through negligence and silos, where we don't share data, we don't know what's needed, but I'm not going there either. We do have enough data to know that will make people poor if they get cancer, and we can do something about it at a stroke.
Absolutely. Preventing cancer in the first place, as you said, Professor Clancy. Is a very good point. Any public health doctor who's ever spoken to me says you can save €8 for every euro you put in prevention in the first place. How do we make, how do we lessen the cost of healthcare by stopping people from developing these diseases? But it's, as you know, it's so hard to get policymakers to agree to that, to put the money there, to see the outcomes. And I know, Colm, you're doing a lot of work in actually trying to put that forward in cancer screening and other areas as well. And would the panel like to comment on this? There's a couple of other people who'd like to make comments as well.
Just to come back, and I mean, it's just amazing, I agree fully with what you're saying. And I'll give you the worst example of all I had was, got back about 10 years ago, I had someone with cancer. In fact, it was my own first cousin. And I was trying to get him a medical card. And I got him a medical card, and they issued it to him for 3 months. And the immediate response of the family was, well, they obviously expect him only to live that long. And it was a terrible message that I've actually sent out to him. Now, at least, we've got a lot of things changed in the whole medical card area. But you are right, there should be one button that you can press where everything else comes into place. And, and that's, the end result is that they're coming to us, people are coming to us because all the barriers that are built up, they can't get over them. And then we're fighting our corner, trying to get through the system, when we shouldn't have to be doing it either. We should be able to press one button and all of the systems go into place for a person that's diagnosed with cancer. And it's a problem, like I gave the example earlier about the people on the difficulties about housing. I mean, a guy, 24, with lung cancer and stomach cancer, and he's in temporary accommodation. That shouldn't be happening.
Thank you. Sorry, this lady here has been waiting patiently to address the panel.
My name is Mary Collins. I'm a primary healthcare worker in Paddy Point. So our job is going out promoting health and helping people to look after themselves and helping people to look for the signs and symptoms of cancer and lots of other diseases as well. But we have a patient at the minute, and maybe a few more along with her, that had her breast removed just say about there in the summer. But she lives on the side of the road, and she's been living there say like all her life. There wouldn't be anything much provided. But at the minute, say with the local authorities, that I really want to go about is that they deliver her like a drum of water every week. She only has a Portaloo toilet, and also when it comes to the post, on post she's missed 3 appointments where they won't deliver. So I'm just talking about, say, from our community, it wouldn't be very big large community, and like we are from Ireland, and like when it comes to health issues, say apart from primary health care, and she's very good doctors and hospitals, but the rest of the local authorities isn't very good at helping. So like even when you come out, there'll be no street lights in case she'd fall, the postman won't go into her, and like even we see this as well during the coronavirus, with large families living in trailers, maybe with one Portaloo. So when the HSE come out to do the mass testing, they see that themselves. So it seems like they're already in a war zone because they have no electric or water. And that's not just that area, that's in loads of the areas where we work. So we're now trying to make people healthy in a situation where they live is even harder.
Thank you very much for your comments. I know doctors and James has pointed out similar issues with even getting appointment notices to homeless patients, and that that they directly reach out themselves through other forms of communication. And that really has to be there for patients. They shouldn't have to fight for that. To miss an appointment, if you miss an appointment or two, you're literally sliced off the list, as you would know, and that's very distressing for patients. And sorry, Stephen McMahon, I know you want to make a comment as well from the
thanks.
Irish Patients
Yeah,
Association.
thanks very much. First of all, congratulations. It's you know, a very thought-provoking report, and I think that has to, you know, be complimented. I would say that I've been amazed that, you know, we hear from Liz Yates there from Mary Keating saying that a lot of what you found was found 10 years ago, and from Avril there also talking about raising why in 2022 are we at the state that we're in. We're a cross disease group, so we'd like to see obviously the button pressed for anybody with a chronic illness, including cancer. But I think that we've got to get back to some very important basics from an advocacy point of view, and that is the language of rights. You have a right to healthcare, an equal right, and when you don't get that access, with all the challenges it has, and you've heard discussed this morning, those rights are violated. And it comes back to an issue, and as I say there, you know, little movement in 10 years on the ground. There's accountability required here. It's fine with NGOs and civil societies and, you know, doctors' organisations and so on trying to improve things. But there is an accountability with the legislators to hold those to account for not either doing the planning and integrating the wonderful skill sets that are around here this morning, simple things that would make a huge difference. So I would just, you know, suggest that we need to start talking the language of rights and the issue of accountability in our planning, because that's really what we're hearing about here. It's all about planning and accountability. And really, if it's not happening to people that are marginalised, well then that's a weakness and we have to deal with that. And as Professor Clancy is saying there are issues there about silos, and we've got to say to people, tear down those silos because patients are being affected.
Absolutely, thank you for your comments. I mean, very good point there, lack of accountability. We used to have healthcare targets and journalists used to report on them, and we'd have the data when the HSE didn't meet those targets for A&E. They stopped publishing them then because they didn't like having, you know, being beaten with that stick. And it should be the same for cancer services, that when the targets aren't met, that we actually proactively report that data and that the government act. In the UK, there's a lot of regulatory authorities in charge of the healthcare service. They fine trusts and organisations for not meeting their targets and their requirements to patients. Whereas here, we bury the data, and as we've pointed out today, there's a lot of data we don't collect, but there's also a lot of data we do collect, we just don't use it. If you look at the HSE's Lennis library, there's huge amounts of data there, and even as journalists, we have to FOI certain data that should simply be published on websites. And as Professor Clancy pointed out, they just don't want to share it. They don't want to give that data, because we do know when you do publish that data, a lot of us did know about the inequality in lung cancer, but if you publish that data, there is media coverage, there is outrage, and then things change. Whereas we shouldn't have to fight for that. Sorry, everyone, just before we wrap up.
Yeah. But yeah, just on that final point, yeah, we still, like, the National Cancer Strategy was published in 2017, 10-year National Cancer Strategy. It includes 2 clear KPIs around what we're talking about today, about closing the survival gap, and no data, and then we're five years in now, to our 6th year of the strategy. No data has actually been published on that. And on the National Cancer Strategy itself, we still don't have the progress report from last year. So here we are at November, planning for next year, and we still don't have progress report of what happened last year. But I suppose if I can finish on a more positive note, it's just sometimes when we talk about these challenges, they can feel, you know, they're complex and they can feel insurmountable, but they're not. You know, as Professor Clancy said, it's not rocket science. We have made huge progress in cancer services in the past. You know, we've gone from 3 out of 10 surviving 30 years ago to 6 out of 10 now, 9 out of 10 in breast, prostate, testicular cancer. Phenomenal progress has been made. Some of that has required difficult political decisions, like the centralisation of cancer surgeries into the centres of excellence. Huge political issue, very controversial for the government at the time, but it was the right thing to do, and we supported it because we knew it would make patient outcomes better. And I think we need to see that same commitment again now, you know, because we can collectively, and it's not just on government, you know, it's on policymakers, it's on the people who work in the health services, it's on people like ourselves, you know, myself, Liz, and others, and Francis and others, to bring forward the solutions, to show what works, to partner, to work together, and have just that sole focus on how can we help everyone affected by cancer, and how can we all step up and achieve that. And I really do believe that it's possible. There's so many positive things happening. There's such amazing research. This pace of it now is phenomenal. We know so much more about how to prevent cancer, how to treat it, and how to give people a good quality of life. And I just think it's on all of us to put aside the silos, put aside all the history around this, and find positive ways to make it happen.
Thank you, Avril. That was a great way to end our panel discussion. I want to thank our panel, Dr. Jerry Mitchell, who is still online, Deputy Colin Burke, Avril Power, and Dr. Francis Drummond. And I know there's more questions, but please feel free to network afterwards and to discuss the findings of this very important report. I'm going to hand over now just to Dr. Shana Cohen just to wrap up our launch today.
Just very briefly, I just want to thank everybody for coming. And if you want to engage more with us on the report, please feel free to get in touch with TASC. We can put you in touch with the author, or we can answer your questions. But like Avril said, we should continue to work together to make things better for patients. And for those who have yet to be diagnosed, we make the pathway easier. Anyway, thank you very much for coming. See you.
Yeah, we're going to call you soon. Yeah.